Morning, everybody. Thank you very much for inviting me to give this talk. When Marissa spoke to me about this, I thought, that's a really interesting topic, and I hadn't reviewed this topic for a while. I always had this vague feeling of discomfort when I had a patient, for example, with chronic kidney disease who was hyperuricemic, whether I should start uric acid lowering therapy or not, and I really didn't know what to do. And so it gave me a great opportunity to review all the recent literature. And as you'll see, sadly, I still am not quite sure what to do. At least I know I've got a background to know that I don't know what to do. So, have you been? On the slide? So I'm going to start with a true case of mine. It was a few years ago, but it really stuck with me. And then I'll talk about these different aspects of uric acid metabolism. So first of all, the case presentation. So this was a patient who had not much of a past history. She was in pretty good shape, had some hypertension, and went to a routine physical to her family doctor. And you can see what her current medications were at the time of that physical. It was a pretty unexciting physical, and nothing was changed, but the family doctor ordered some blood work and let her go on her way. And here was her blood work, and her kidney function was normal, but she did have elevated serum uric acid level. No history of kidney stones, no history of gout, or anything like that. So the question is, should she be on therapy to lower this elevated serum uric acid? And the family doctor got these results and called her back in and prescribed allopurinol, 300 milligrams daily. And a couple weeks later, this is where I came in, she developed fever and umbilical skin rash and eosinophils, peripheral eosinophilia, and the creatinine, which had been, I think, 76 or something, was now 422 micromoles per liter. And she was sent to me urgently as an AKI. And I had a look in her urine, and she had white cells and white blood cell counts in the urine. I didn't even do a biopsy on her because it was pretty clear what the diagnosis was here of acute allergic interstitial nephritis secondary to the allopurinol therapy. So we stopped the allopurinol, of course, and put her on half a milligram per kilogram body weight of prednisone. And she had a slow improvement both in her kidney function and in her symptoms, the fever and the rash, things like that. But she was left with some chronic renal impairment. And this case really stuck with me because this was someone who was perfectly well, just had some mild asymptomatic hyperuricemia, and ended up with an AKI episode and was left with impairment of her kidney function. So let's talk about the close relationship between chronic kidney disease and hyperuricemia. As you all know, uric acid is the end product of purine metabolism in humans, not in other animals, but in humans, and most of this is in the form of monosodium urate. And the plasma concentration of uric acid will depend, of course, on the balance between production and excretion. And nephrologists and nephrology pharmacists are often involved in this because the kidneys are very important for the excretion of uric acid and therefore maintaining a normal uric acid level. Now, interestingly, the solubility of uric acid in the urine is dependent on the urine pH. And if the urine pH is very acidic, it promotes precipitation of uric acid. Even if there isn't a ton of uric acid in the urine, it will precipitate if the urine happens to be very acidic. And in fact, many years ago in Toronto Western Hospital, one of our doctors described recurrent uric acid stones in a population of Portuguese immigrants to the downtown Toronto area. And they did not have increased uric acid excretion, but they seemed to have persistently acid urine as the principal risk factor for it. Something else that makes the urine persistently acid is volume depletion. may know that American soldiers who were stationed in Guam during the Second World War, which is a very hot tropical place, were felled more by kidney stones than enemy fire because of an epidemic of kidney stones because of this persistently acid urine. The kidney's handling of uric acid is very complicated, and I really can't figure out a good teleologic reason for it. There are uric acid-specific transporters, especially the proximal tubule. So uric acid itself is freely filtered at the glomerulus. It's reabsorbed in the proximal tubule. It's secreted, and there's lots of things like potassium that are reabsorbed and then can be secreted as needed. But it's also reabsorbed again. So post the secretory sites, there are further sites where uric acid can be absorbed. So that's really interesting. There aren't a lot of solutes that have this basically this triphasic handling by the nephron of reabsorption, secretion, and reabsorption again. So, as I said, it's not really clear why that is. So there are many factors that can increase renal uric acid excretion, and that includes volume expansion with increased GFR and increased urine flow rates. Estrogens can increase uric acid excretion, and it's felt to be one of the reasons why in population studies women tend to walk around with lower serum uric acid levels compared to men. And hyperuricemia, again, probably by increasing urine flow rate by osmotic diuresis. And there are pharmacologic agents also that can increase renal uric acid secretion and lower the serum uric acid level. And those that inhibit reabsorption you know about, so high dose salicylates, probenecid, I've been doing this a long time. Probenecid, radiocontrast dyes, high dose vitamin C, and interestingly, losartan also. Not the other ARV, but losartan. I'll come back to that in a minute. But these can increase uric acid excretion by the kidneys and lead to lower serum uric acid levels. Then there are agents that can decrease uric acid excretion by the kidney and lead to elevated uric acid levels. And you can see the list there, low dose as opposed to high dose salicylate, the antituberculous agents, nicotinic acid, ethanol, of course, you all know about that association, and the loose diuretics. And then there are also ones that increase reabsorption by the tubule, probably the opposite mechanism of volume expansion leading to excretion by the tubule. If you induce sodium avidity or volume depletion, you can increase uric acid reabsorption by the tubules, and that can lead to elevated serum uric acid levels. So clinically, the important ones, of course, are the diuretics that lead to increased uric acid reabsorption. As is not surprising, as the kidneys are responsible for the vast excretion of uric acid, once kidney function decreases, hyperuricemia supervenes. And most workers feel that as opposed to defects in tubular transport, it's really all just the fact that there's a fall in the uric acid, there's a fall in the GFR. And it's a fall in that GFR that leads to a retention of uric acid and therefore hyperuricemia. Now here's where things get interesting because for many years there was a strong association between chronic kidney disease and elevated serum uric acid. And there are observations that patients who had gout, when they died and they had postmortem, that they had glomerulosclerosis and fibrosis in the tubulointerstitium. And also uric crystals were found in the renal tubules. So these are people that had gout, they also had chronic kidney disease, and they had evidence of uric acid crystals in the kidneys. So it was quite logically assumed that there must be an association between the hyperuricemia and gout and the chronic kidney disease. And this, you can see this is a paper from 1960. They made this association and they called this gouty nephropathy with the assumption that there was something intrinsically harmful about uric acid that led to kidney damage. And then around 1982, this was a very high-profile paper in the American Journal of Medicine by Joanne Bargman, and they said, you know what? They looked at a lot of people who had gout and chronic kidney disease, and they looked at people with gout without, and they did physiologic studies in a cohort of patients with gout, and they found that really there was no evidence that hyperuricemia and gout by itself affected the kidney function. And I have this quote here from their paper. Renal insufficiency, when seen in patients with gout, usually correlates with the coexistence of hypertension, ischemic heart disease, or primary pre-existing renal insufficiency. So Joanne Bargman challenged this idea of gouty nephropathy and said, really, the chronic kidney disease in these patients, it just happens because these patients who get gout tend to also have a lot of vascular disease, what would eventually be referred to as metabolic syndrome or syndrome X, and that's why they had chronic kidney disease, and it had nothing to do with the uric acid per se. So you can see that the pendulum first swung towards uric acid being a potential renal toxin, and now with the publication of this paper, it's swung back to say that no, uric acid is basically a result of all this and not a cause of it. And the chronic kidney disease is because of these patients' comorbidities. So this really held true for the next couple of decades. And it was thought that hyperuricemia is the consequence of renal disease, not the cause, and that it was all the other stuff going on in these patients with their vascular disease that was the cause of their chronic kidney disease. So really, it sort of asked the question, what came first? Was it the hyperuricemia leading to the chronic kidney disease, or the chronic kidney disease leading to the hyperuricemia? So this, as I said, went unchallenged for about 20 years until a group of investigators spearheaded by Rick Johnson, who I think at the time was in Florida, started to revisit the old gouty nephropathy concept. And they did this interesting study where they fed a uricase inhibitor, oxalic acid, to rats. And this led to elevated uric acid levels. So the only thing they changed was that they induced hyperuricemia. And what they found was that these hyperuricemic rats ended up with higher blood pressure, worse proteinuria, and more glomerulosclerosis compared to the rats that did not get the induced hyperuricemia. They also found that there was increased expression of renin and of COX-2 in the nephrons, which of course would lead to progressive vascular damage and also fibrosis. And what you see on that graph there is increasing serum uric acid on the x-axis in an American unit, and increased renin expression in the glomeruli in the y-axis. And they said these studies provide direct evidence that uric acid may be a true mediator of renal disease and progression of chronic kidney disease. So this was now the pendulum going back for the third time. It's kind of interesting because I saw this parallel between uric acid being absorbed, secreted, and absorbed, and this pendulum of uric acid is a renal toxin. No, it's not. Yes, it is. So, and then this paper was followed by a bunch of other papers that seem to suggest that hyperuricemia could itself be intrinsically toxic. So, I'm just sort of summarizing them for you. These were mainly animal studies or in vitro studies. They showed that isolated hyperuricemia could increase oxidative stress in the kidney. It seemed to lead to increased blood pressure, which comes back to the issue of maybe it's a vascular toxin in addition to a renal toxin. It caused renal tubular cells to change into more fibrosis-producing cells. This is called epithelial mesenchymal transition, and it just means that the cell turns into a kind of cell that produces fibrosis, which may be a mediator of chronic kidney disease. And again, in terms of whether this could be a vascular toxin, it was found again in vitro studies that uric acid could induce endothelial dysfunction by changing nitric oxide synthesis and inducing insulin resistance. So although there is this association between hyperuricemia, vascular disease, and insulin resistance, these things suggest that the uric acid itself perhaps could do that. So this paper came out in New England Journal that challenged this concept, and they really prefer to get away with Johnson leading this, saying that uric acid, in fact, like what had been found decades before, was perhaps a cause of vascular disease and renal disease, and not a consequence of just having a decreased GFR. And they showed all these studies that I just summarized for you, showing that very often uric acid predated the development of high blood pressure and so on, and therefore could be causative with these morbidities. And this is a nice slide. I hope you can see it. It's a nice, good-looking slide from the New England Journal. And really, it just shows you the different mechanisms, how you can end up with increased uric acid. I can use the mouse here. Well, if you see in the middle, it says increased uric acid. You see that? So, genetic factors, if you happen to be born with fewer than a normal number of nephrons, or you've got chronic kidney disease, and interestingly, they also looped in fructose. So, as you know, this is a whole other avenue of exploration, that many of the foods, modern foods now, including sodas or pops, are sweetened with high fructose corn syrup. And fructose, when it's broken down, breaks down into purines, and purines break down into uric acid. So perhaps there is an increased incidence of hyperuricemia and gout in developed populations. One of the things is that it's the result of everything is being sweetened these days with high fructose corn syrup. So that's the one on the left there, the fructose heavy diet, leading to increased uric acid, which can affect the kidney and can also affect vascular health. And both of those can lead to progressive chronic kidney disease, as goes the hypothesis, and also other vascular diseases, such as hypertension and vascular disease. So, does hyperuricemia accelerate the decline in kidney function over time? And again, this is something I struggle with. I see someone and they've got chronic kidney disease, you know, the creatinine's like 180, 200, and they've got a serum uric acid of 600. They don't have stones, they don't have gout, but I worry about whether that hyperuricemia is in fact making the kidney function decline over time. And again, there's not a lot of very good literature about that. We know that hyperuricemia, as I showed you before, does seem to predict a greater chance of developing chronic kidney disease, but in people who already have chronic kidney disease, like the patients I struggle over, does hyperuricemia actually lead to a faster decline in kidney function? And there have been a lot of studies looking at this. They're very small studies. And perhaps the most hopeful one came out of the CRIC cohort. So let me just tell you a word about this cohort. This is over 3,000 patients with chronic kidney disease, an inception cohort at the turn of the century. And they said the GFR was between 20 and 70 mils per minute, and they're really kind of like the Framingham. They're like a studied cohort to look at the progress of chronic kidney disease over time. And happily for us, they decided to look at serum uric acid in this chronic kidney disease cohort. And so you can see that baseline serum uric acid was measured in the majority of these patients. They had about an 8-year follow-up, and then they looked at whether the uric acid predicted whether they would go on to kidney failure. Unfortunately, I found that the results were very disappointing. There was a very strong interrelationship between the level of the GFR and the uric acid in terms of predicting worse GFR. And I'll show you this, but for people who had chronic kidney disease, stage 2 or 3A, yes, the higher the uric acid, the greater the chance that they would progress to end-stage kidney disease. But as you got to worse kidney function, stage 3B, there was a bit of an increased hazard ratio for hyperuricemia leading to progressive and end-stage kidney disease. It wasn't statistically significant. Okay, only 3,000 patients, whatever. But in patients who were stage 4, who had high serum uric acid, it was actually protective. against going on to worsening kidney failure. So, I mean, what are you supposed to do with that? How does that really help you? So during their follow-up, almost 800 patients died, and they found a J-shaped relationship with those who had very high uric acid were more likely to die, and those that had very low uric acid were more likely to die. This shows you the quartiles of serum uric acid, again, in American units, with the lightest one being the lowest serum uric acid, and the darkest one being the highest baseline serum uric acid. And you can see that for overall, the higher the serum uric acid, the greater the chance that the patient was going to progress to end-stage kidney disease. But when they did it, as I said, by the stage of end-stage kidney disease, so first of all, everyone taken all together, it was really basically a wash. And if you look at people, as I said, with the earlier stages of chronic kidney disease, as you might expect, the higher the serum uric acid, the greater the chance of progression. But then when you got to the GFR between 30 and 44, it was, as I said, not statistically significant. And then when you got to less than 30, it went to the other side of the prediction value, and it was actually protective against going on to end-stage kidney disease. So, you know, this is why this was published here and not in the New England Journal. It's certainly the largest study to date, but it's really hard to know what to make about these kinds of results. And this is the J-shaped curve that I showed you before. So the hazard ratio of mortality is on the y-axis, the uric acid is on the x-axis, and again, low uric acid, perhaps a sign of malnutrition, I don't know, but maybe low uric acid, and very high uric acid were associated with an increased risk of mortality. So that's the crick cohort. The next question, of course, is, all right, there's some signals that maybe high uric acid is associated with worse outcomes. It could be a vascular toxin. It could be a renal toxin. Should we be lowering the serum uric acid, and will that help? You know, there's a lot of things in medicine where there's an association, but if you try to change things, there's really very little evidence that it helps. An example might be left ventricular hypertrophy. We know that left ventricular hypertrophy is associated with a lot of bad downstream events, like cardiovascular events and death and so on. But reducing left ventricular hypertrophy hasn't been robustly shown to actually reduce the chance of these events. So the same thing follows here. If you believe that hyperuricemia is associated with bad things happening over time, does lowering actually make a difference to that? And again, it's a very difficult subject. I just want to bring up, remember I mentioned before that losartan, interestingly, probably by its effect on one of the proximal tubular transporters of uric acid, is associated by and by with the uric acid lowering effect. And the Renal trial, you remember, was that of losartan in type 2 diabetes, looking at cardiac outcomes and renal outcomes. And it was a positive study. But the question is, was the effect of losartan due to its ARB effect, blood pressure lowering effect, hemodynamic effect, or was it due to the uric acid lowering effect? So this was a post hoc analysis of the Renal trial. They did confirm that the group that got losartan went through the study with a lower serum uric acid level than those that were in the other antihypertensive drugs, and that was statistically significant. And then they found that lowering of the serum uric acid was associated with a decreased risk of bad renal outcomes. And through statistics that I don't really understand, they came to the conclusion through this analysis that about 20% of the renal benefit in the Renal trial with losartan could be attributed to its uric acid lowering effects. So that's that for you. And then there's a lot of trials with allopurinol. So there's lots of them, but I just want to highlight a couple of the more recent and perhaps more important ones. There's a randomized controlled trial in people with CKD, randomized to allopurinol or not. They had a baseline creatinine around 200. A sizable number of them were diabetic, and it was a one-year trial. And what you see here is the allopurinol group on your left, and the control group on the right. And what it's supposed to show is the creatinine level at the beginning and 1 year later. And you can see that the group that had allopurinol did have an increase in their serum creatinine over the year, but not as much as the group that was the control group. Now, the control group did start off with a little bit of a higher serum creatinine than the allopurinol group, but still, it was a bigger jump in serum creatinine in the control group compared to the allopurinol group. And when we looked at the one at the endpoint analysis here, you can see that when they looked at significant deterioration in renal function over that year, that there seemed to be a protective effect of those getting allopurinol compared to conventional therapy. And here's another randomized controlled trial. Here, allopurinol 100 milligrams a day versus usual therapy. The baseline serum uric acid was about 7.5 milligrams per deciliter. The upper limit for men, I think in these units, is somewhere around 6. So this would probably be about 600 or something, 650 micromoles per liter. And here, allopurinol was associated with stabilization or even increase in GFR, that's the dark box there, as opposed to the control group where over the study period there was a drop, not unexpected drop in GFR over the course of the study. So the allopurinol group actually had a 1.3 mil per minute increase in GFR over the study, which makes me very nervous. And I just want to say that if any of you remember the bardoxolone study, does anyone remember that bardoxolone, where in fact it increased, in people with CKD, it increased GFR. Everyone got really excited, and then no one could ever reproduce the bardoxolone data again, and it went off the market. And to me, anything in chronic kidney disease that makes the GFR better than at the start, I don't believe. Okay, because fibrosis is fibrosis, tubular justicial atrophy is atrophy, and you can't bring it back. So I would be very suspicious of a study where you put them on allopurinol, and a year later the GFR is better than when you started. And also in the study, there was a significant reduction in cardiovascular events and a significant reduction in hospitalization in the allopurinol group compared to the control group. Again, if you believe that uric acid is a vascular toxin, and there, as I said, there is a lot of basic work to support that, then you might expect a reduction in cardiovascular events. But this was really quite dramatic in this study. And this is just looking at brachial artery blood flow. This wasn't an outcome study, but just looking at brachial artery blood flow in patients with stage 3 CKD who received or didn't receive allopurinol for asymptomatic hyperuricemia. And in this particular study, the allopurinol, not surprisingly, lowered serum uric acid levels, but it didn't make any difference to brachial artery blood flow, which is a surrogate for vascular function. Again, it was only a 12-week study, and maybe it wasn't enough to show anything. So really, I've summarized for you the major studies about allopurinol and whether, in fact, it can help in patients. So sort of a neutral study, frankly, a too-good-to-be-true study, and a vascular study. So, here's where meta-analyses or systematic analyses should bring more of a clarity to the subject. So I could find a few of these, and they all have interestingly Toronto connections. But let's look at this first study. They took English-only studies and they did a systematic analysis. And the dose of allopurinol in these studies was anywhere between 100 and 300 milligrams per day. And when they did the meta-analysis of it, you understand these kind of plots. Does it favor allopurinol or does it favor the control? And the overall calculation is that big black diamond, and if it crosses 0, then it's not statistically significant. But you might say that there seems to be a lot of ones more on the favor allopurinol side, but it's still not significant. And the authors thought that the study numbers, there weren't enough studies around, they were too different from each other to join together, and that they really couldn't make any conclusions in the systematic analysis about use of allopurinol and progression of chronic kidney disease, and they thought that better trials were needed. So that's sort of my reaction. And here's a second meta-analysis, also from Canada. Here they didn't look at just English studies, but they looked at the multi-language studies. So you can see they screened almost 5,500 studies and ended up with 19, and then finally ended up with 11 studies for the meta-analysis because they were greater than 3 months duration, which I think is a reasonable screening tool. And here's that same sort of a plot again. So you can see they changed in the serum creatinine, that it seems to favor allopurinol, and that was just looking at GFR, but you can see that again, it seems to favor allopurinol in these studies. But the author said that the results are, quote, suggestive and encouraging, but to make a recommendation to use allopurinol for hyperuricemia would be premature. And guess what? Well-powered, randomized, controlled trials. So the other meta-analysis, also from Canada, I don't know what it is about Canada, but they looked not only at allopurinol for chronic kidney disease, but also for gouty arthritis and for cardiovascular events. And they found that out of almost 1,700 papers they screened, that 3 met the inclusion criteria, 2 to prevent renal disease, and 1 to prevent progression of chronic kidney disease. And the authors concluded, guess what? That the literature is sparse and fraught with limitations. Pharmacologic treatment of asymptomatic hyperuricemia cannot be recommended at present for the prevention of gouty arthritis, renal disease, or cardiovascular events, and further well-conducted studies. So there are, in fact, trials underway, and here's some major ones that I found. I went to clinicaltrials.gov, and you may have heard of some of these. The one from Australia, CKD6, a colleague of mine is the principal investigator of that, and I emailed him about it, and he says that they're hoping that they're going to have the first results perhaps by the end of this year, looking at, again, as you can see, slowing progression of chronic kidney disease with the use of xanthine oxidase inhibitors. So that's really where we are in 2018. We know that hyperuricemia as a risk factor for cardiovascular events or for progressive kidney impairment is really confounded by the fact that it ties in with decreased GFR anyway. Directly, and as I said, this is swung back to this idea. But so there is a physiologic rationale to treat asymptomatic hyperuricemia if you subscribe to this idea that uric acid is itself toxic to the kidney and to the vasculature. But really, as I've shown you to date, with all the studies and the data that we have right now, there's little good evidence to support it, and that's where we are now. So I hope that with the 113 trials that are in clinicaltrials.gov, that perhaps I can come back and tell you something in the future that just gives us more guidance about treatment of asymptomatic hyperuricemia. Thank you very much.